So welcome everybody. As we're starting, I'd like to recognize that I'm joining today from Jojage, now known under the name of Montreal, on the unceded traditional territories of the Kanien'kehá:ka Nation, part of the Haudenosaunee Confederacy. At CAM, we recognize the Kanien'kehá:ka Nation as the custodians of the lands and waters of Jojage. We also recognize the historical and continued violence of settler colonialism and are committed to learning and working toward reconciliation through collaborative and reciprocal relationships with Indigenous peoples and communities. I'm very pleased to welcome you to this webinar on preventing RSV in infants and current immunization options. My name is Valérie Perrault, or Valerie. My pronouns are she, her, and elle. I'm a midwifery technical expert working for CAM since May 2023 as part of the national team. So before we start with the presentation, here are a few housekeeping items. So as usual, there will be a question period at the end of the session. Feel free to drop your questions in the chat and we'll gather them and address them at the end. If you need any technical assistance, my colleague Bryn is on standby to help us with any issues. As usual, the recording of the webinar will be available and the slide deck will be available early next week on the website, on the CAM website. Et pour nos collègues francophones, on n'a pas de traduction simultanée aujourd'hui. Des sous-titres vont être ajoutés à l'enregistrement de la présentation qui sera disponible sur le site web. Just explaining about the subtitles that will be available on the presentation next week. So it's now my pleasure to introduce Dr. Jasleen Kaur-Grewal. Dr. Grewal gave some popular talks last year, as we were just saying at the beginning of when we started chatting. So it was a full year ago that Dr. Grewal gave a talk during the CAM conference and another one also during the winter in past February. But this time we're really happy to welcome her again so she can provide us an update about current immunization options in particular. Dr. Grewal is a certified family medicine physician. She completed her medical education at the Schulich School of Medicine at Western University in London, Ontario. And her current work and her residency training in family medicine at the University of Toronto. Her current work includes inpatient newborn care, along with a special interest in reproductive, contraceptive, and gynecological health at multiple sexual health clinics. She's the current medical director at IWHC Toronto and is passionate about improving access and providing care to diverse and vulnerable populations. So I'll stop sharing my screen and pass it over to you, Dr. Grewal.
Thank you so much, Valerie, for the introduction. I'm very excited to be here again today to talk to you about some new immunization options. Just confirming everyone can see my slides there.
Yes, I see them fine. Thank you.
Perfect, great. And yeah, thank you for welcoming me again. I'm grateful to be here. There's a lot to discuss about the exciting new immunization options available for preventing RSV in infants. So let's talk about it. These are my disclosures. And we'll discuss everything you need to know today for the upcoming 2024-2025 season. We'll remind ourselves of the burden of RSV disease, the kind of risks that it poses to infants and why we need to care about it. We'll do an overview of the available products that are new to the market, including Beyfortus and Abrysvo, the monoclonal antibody and the vaccine for pregnant individuals, how to use it, as well as dive into some of the clinical data that got it approved, and the real-world evidence from its use in various countries over the last year. Finally, we'll discuss NACI recommendations for RSV prevention, how to practically implement these new approved products into our practices, and pathways for administration. So let's get started. We know that RSV is a pretty common respiratory virus. Parents know about it well, and it's only starting to be talked about now because we finally have a way to prevent it. So we know that it's a part of the parainfluenza family. RSV has a seasonal kind of peak, usually around December, but the season starts November to the end of March. This can also change depending on the jurisdiction that you're in. So in northern communities, it starts a little later and goes on a little bit longer. And then, in the Southern Hemisphere, it's completely flipped. So it really does depend on where your family is headed and where they're planning to live after delivery as well. We know that most RSV infections are mild. They cause, flu or cold-like symptoms, a runny nose, sneezing, cough, and most of them resolve on their own, like any other virus would, within 3 to 5 days. There's so many colds that people think, I got the flu shot and I still got sick. Often that's RSV. We know that most people have that mild infection, but there's a select few people, high risk individuals, as well as infants, especially in their first year of life, that can go on to develop serious respiratory problems and severe illness. We know that RSV is the most common cause of bronchiolitis and pneumonia in infants. It's actually the leading cause of pediatric hospitalization, and worldwide mortality is as high as 5%, highest in countries without access to good health care. So this is global data, but Canadian numbers are quite similar. We know that 90% of infants will be infected by RSV before their second birthday. That's virtually every infant will catch this virus. It's quite prevalent. The majority of these cases, as I said, are mild upper respiratory tract infection, but severe cases can require hospitalization. And 5% of those healthy infants that are hospitalized with RSV will go on to actually require ICU or PICU admission. In Canada, approximately 1% of all live births are hospitalized with RSV in their first year of life. And in some remote communities, those numbers go up as high as 20 to 50% of all live births. I also want to point out that a lot of the burden might be underestimated, including the numbers shown here, because we're not always doing PCR testing for those infants, especially if they're being seen by myself in the community as a family doctor or urgent care. We're not always doing PCR swabs to confirm whether the illness is RSV. And sometimes even in hospitalized infants, it's not coded as RSV. So often these numbers are a bit underestimated. And we weren't really focusing on coding it because we didn't have a way of preventing it before this. So it's really an exciting time and changing landscape in the world of RSV. So this slide really shows that the majority of RSV hospitalizations occur in infants without risk factors. We know that severe RSV disease is quite unpredictable, meaning we don't know who it's going to happen to. Any infant can be hospitalized in their first season, whether they're born at term, whether they're premature, or they have underlying health conditions. The course is quite unpredictable. So actually, according to a Canadian study done in Ottawa, CHIO, they looked at RSV hospitalizations across about a 7-year time frame, I believe 2005 to 2013. And they looked at all the infants that were hospitalized with RSV at a given period. They found that 80% of them were actually previously healthy and born at term, and still required hospitalization with severe RSV disease. So it really highlights that we need to protect all infants, not just those with risk factors, prematurity, or underlying health conditions. And we see this all around the world, where the majority of infants hospitalized and admitted to the ICU with severe RSV actually have no underlying medical conditions. I actually think that's a really important point to bring home and share with our families and parents as we counsel around the importance of preventing against RSV, because it can happen to any baby, even a healthy child. So this graph really shows we want people to understand that it doesn't matter the timing of birth. So it's not just infants born during the RSV season that are hospitalized. We see that 68% of hospitalized infants were born before the RSV season, and then the remaining 32% were born during the RSV season, which means that all infants are at risk of severe RSV, regardless of their birth month. This risk is highest for infants entering their first RSV season, and we'll see that the majority of hospitalizations do occur for children 12 months or younger. So how do we prevent this from happening? Let's do a broad overview, kind of differentiating the different kinds of immunity that are available. There's multiple immunization options, but most patients are used to active immunity. This is what we see with typical vaccines. It's a protection produced by a person's own immune system, where the individual is exposed to an antigen in a vaccine and then develops their own immune response, so an antibody, in response to getting that vaccine. This is active immunity. It requires activation of the immune system, is how I like to remember it. And active immunity can last many years or even a lifetime. In contrast, there's passive immunity. This is protection offered by an antibody produced by one animal or human and then transferred to another, the one that we're trying to protect. Passive immunity does provide immediate protection against infection, but we know that that protection is a lot more temporary than active immunity. What's interesting is that both of the currently available immunization options for RSV prophylaxis are a form of passive immunity, and I'll explain how. They both offer immunity that's quicker than active, but it does wane a little bit quicker as well. So in the case of RSV prophylaxis, we have two options for protecting the infant. The first is monoclonal antibodies, which what are they? They are synthetic or lab-made proteins engineered to kind of emulate the body's natural defense mechanism against pathogens. So it kind of mimics the natural antibodies that our body would have produced without using the immune system to make it. We make it kind of in a lab, including RSV. So monoclonal antibodies, also known as MABs, act by targeting and neutralizing specific pathogens, which can prevent or limit disease. The currently authorized options include palivizumab for infants at high risk and nirsevimab. We'll get into the details of each of these. And the second option available for RSV prophylaxis is a vaccine. As we know, it's intended for the pregnant individual. And what it does, it actually confers passive immunity. The pregnant individual creates the antibodies, and then they're transferred through the placenta to the infant, designed to protect the infant from birth. So again, both of these are a form of passive immunity to the infant. Either the antibodies are made in a lab or they're made in a pregnant individual and transferred through the placenta. So either way, the baby will be getting preformed antibodies. This slide really summarizes the available options. There's two monoclonal antibodies, palivizumab, trade name Synagis, and the new one, nirsevimab, trade name Beyfortus. And there's only one vaccination available during pregnancy. RSV prefusion vaccine is what you'll see in the studies, with the trade name a lot easier to say is Abrysvo. So let's talk about palivizumab. So prior to last year, this was the only existing option for RSV prophylaxis in Canada. It's called Synagis, and it's a monoclonal antibody as well. We've been using this for about 20 years. It was Health Canada approved in 2002. And it's been used for over 2 decades in a bunch of other countries as well. With rare cases of anaphylaxis being the only major serious adverse event, it had a pretty good safety profile. The efficacy was not as good as the new ones. It was about 38 to 78%. However, it did come with a bunch of other challenges. This medication did have a monthly dosing schedule, which means it had to be given every month for about 5 doses during the entire season in order to adequately protect the infant. This is challenging for people in remote and northern communities with limited access to healthcare to have to, drive out to go receive the antibody once a month. It also had a very limited and tight eligibility criteria. It only included premature infants or those with significant comorbidities like chronic lung disease, cystic fibrosis, etc. With this limited eligibility criteria, using a risk scoring tool, the pediatricians would kind of determine if a baby qualified, and only about 3,000 infants were able to get this medication per year. Many were turned down, and we've just learned that since 90% of babies get sick with RSV, it left kind of a huge gap of the population of infants that simply didn't qualify to get any RSV protection. And therefore, there was a need for additional options. So this is what we have available in the current season. We have 2 new options available to protect infants. The first is Beyfortus, also known as nirsevimab. This is the second monoclonal antibody to ever be approved for protecting infants. And it's actually been Health Canada approved as early as April 2023, indicated for all newborns and infants during or entering their first RSV season, as well as a select few individuals of children up to 24 months of age who remain vulnerable to severe RSV in their second season. The beauty of this is that it's the first time that a prophylactic strategy has become available for such a broad infant population. And then in December 2023, Health Canada did approve Abrysvo as well, which is the vaccine intended for pregnant individuals approved by Health Canada in December 2023, indicated to immunize pregnant individuals to protect their infants from birth through to 6 months of age. It also has a second indication, which we won't go into today, but it's important to note, is that it's the same vaccine, same dose, same vial, everything, intended to protect individuals 60 years of age or older, also from RSV, because that population is also high risk. So not to be confused with RXV, which is another vaccine only intended for older individuals, not for infants. Not for pregnant individuals, to protect infants. So the way that this works, it's a single dose administered at 32 to 36 weeks gestational age. In a similar way to the way we administer Tdap, it also offers passive immunization to the infant. It's important to note here, though, that in order to work well, Abrysvo does need at least 2 weeks between administration and delivery to allow for enough time for the antibodies to actually transfer through the placenta. I think it's important also to take an opportunity to highlight here the distinction between the two immunization options. Both are a form of immunization, but one is a vaccine given to the pregnant parent. The other is a monoclonal antibody given directly to the child. I find it makes a difference for families, especially during a time where we're experiencing a lot more vaccine hesitancy, to mention that Beyfortus is not actually a vaccine. It doesn't rely on the child's immune system to mount a response, and therefore it actually has a much more favorable side effect profile. And I think that families really like to hear about that. It's a pre-made antibody. It doesn't need the baby's immune system to turn on to work. So this slide is a nice one because it really summarizes all three of the available options in one go. Nirsevimab, the long-acting antibody for all infants. Palivizumab, the old one, it was a short-acting antibody only for high-risk infants. And then Abrysvo, the vaccine for pregnant individuals, 32 to 36 weeks, but also intended for older adults 60 years or older. So those were the product monograph indications. Let's talk about the difference between Health Canada and NACI. So while Health Canada really focuses on individual use of a product, NACI recommends things on a public health level, and it suggests how to use a product for public programs and population level recommendations. And it's a bit different and kind of distinct from what we would see from Health Canada. So let's look at what NACI recommended and some of the data that NACI looked at to come up with their recommendation. How do we decide which of those three options to use? NACI gives us some answers. These are the three recommendations from NACI's statement that came out early this summer. They evaluated the evidence on both products, Nirsevimab and Abrysvo, and came out with a statement. Let's talk about their first recommendation. It was a strong one, and really what it was is recognizing that RSV is a problem. There's a significant burden of disease, especially on infants and on the Canadian healthcare system. And they recommended building towards a universal immunization program for all infants. So really highlighting that we need to protect all babies, not just those high-risk ones. They did say that this could occur in stages depending on supply, cost effectiveness, and affordability. And their second recommendation, it was also a strong one. It recommended that if we are going to do a universal RSV immunization program, that we use Nirsevimab to prevent RSV disease. This was a strong preferential recommendation for Nirsevimab over Abrysvo. It was based on an evaluation of the data, not only the efficacy data, the duration of protection, but also the safety data. And we'll get into the nuts and bolts of that in a few slides. The final recommendation was a discretionary one, and really it said that the Abrysvo, the RSV prefusion vaccine, may be considered on an individual decision, case-by-case basis, made with a pregnant person and their pregnancy care provider. So in advance of or during the RSV season to prevent RSV disease in the infant. But at this time, NACI didn't recommend a universal immunization program using Abrysvo. So let's look at some of the data that NACI used to really make their preferential recommendation for Beyfortus over Abrysvo. I'd like to highlight the three studies, the pivotal trials that got Beyfortus approved. The first two, study 3 and the Melody study, they were looking mainly at healthy infants, so whether they're healthy preterm or healthy term, and they were comparing Nirsevimab with placebo. Their primary outcome was something called medically attended RSV-associated lower respiratory tract infection, which is a mouthful, but really it meant any RSV-associated visit to a healthcare provider, whether it was a physician's office, an urgent care center, or an emergency room. Their secondary outcome looked at RSV-associated hospitalizations, so those more severe cases. And the last study, this was also a randomized control trial, the Medley trial, but really it was looking at those high-risk infants, those infants that probably would have gotten palivizumab with congenital heart disease, chronic lung disease, or prematurity. And it was comparing Nirsevimab with palivizumab. And it was really a safety trial just to make sure that Nirsevimab had a similar safety profile to palivizumab. I think what this slide highlights is that Nirsevimab was well studied in kind of a wide range of patient populations, healthy term, healthy preterm, and then more high risk, more sicker babies as well. In terms of Abrysvo was also well studied in two kind of primary trials, a phase 2b and a phase 3 clinical trial called the Matisse trial, also published in the New England Journal of Medicine in April 2023. Any of us are welcome to pull this up and look at the nuts and bolts of the trial, but a quick summary: it was a global study. It enrolled healthy pregnant individuals under 49 years of age between 24 and 36 weeks of gestational age. And so kind of a wider administration window than what NACI currently recommends, which is 32 to 36. And the endpoints were similar in this study in that they looked at medically attended lower respiratory tract infections, as well as RSV-associated hospitalizations, but the definitions of those endpoints varied. Still, NACI did a meta-analysis on the data available at the time for each product, which is summarized here. I really want to highlight that it wasn't a head-to-head comparison, and we can't compare two separate trials because the endpoints did differ in terms of definitions. But this is the data that NACI came up with to make their recommendations. So looking at looking at nirsevimab, which is the Beyfortus, when we look at medically attended lower respiratory tract disease caused by RSV, in the group that did receive nirsevimab, we see an 80% reduction in the amount of medically attended visits, an 81% reduction in the hospitalizations, and 90% reduction in severe RSV that led to ICU admissions. What's good about nirsevimab is that the effect is immediate. It's right after administration. You don't have to wait for it to work. And they talked about the duration of protection, which is important to highlight because for nirsevimab, it's quite long. In the first clinical trials, they confirmed it was at least 5 months, and then newer data is coming up saying it's effective up to 8 months, and some data even says 10 months, like the SOGC guidelines. In comparison, Abrysvo for medically attended lower respiratory tract disease had an efficacy of 51%, for hospitalizations was cited to be 57%, and for ICU admission was cited to be 43%. And remember that we need at least 2 weeks between administration and birth. They noted that it was somewhat efficacious in the first 5 months, but the protection does wane quicker than nirsevimab. The duration of protection is not as long. It's not expected to last more than 4 to 5 months. So it was a combination of the duration, the efficacy, and then we'll later talk about the safety that really led for a preferential recommendation for nirsevimab. Sorry, just having trouble advancing the slide here. Give me one moment. Technical difficulties. There we go. Perfect. So how does Beyfortus come? This is a really practical and handy slide, I find. So we see that it comes in 2 different doses, 2 different boxes. There's a 50 milligram box and a 100 milligram box. So really for infants and born during their first RSV season, so this is the all infants, it's weight-based dosing. So if they're under 5 kilograms, it's 50 mgs. If they're over 5 kilograms, it's 100 mgs. And it really does depend on their body weight at the time of administration. It's not birth weight. So that's important to keep in mind. For most of us, like myself, doing newborn care, if we're seeing babies in the hospital right at delivery, they're probably going to fall into the 50 milligram category. And then for some of those children that still qualify in their second season, these are the children up to 2 years old who continue to remain vulnerable because they're high risk, they have many conditions. Again, you or I, most of us primary care providers are not caring for these children. They're typically followed by a pediatrician because they have those conditions, but they will then get the 200 milligrams. It's no longer weight-based. It's an IM injection. It's preferably in the anterolateral aspect of the thigh, and the glute should not be used. In terms of concurrent administration with other vaccines, this is a really common question, and we do have guidelines around it. So starting with Beyfortus, it can be given concomitantly with childhood vaccines, including live vaccines. There is no information regarding co-administration with Beyfortus and other immunoglobulin products. But in terms of co-administration with routine pediatric vaccines, in healthy preterm and term infants, it was studied that given together, they had similar safety and reactogenicity profiles as vaccines given alone. They also important thing to note about nirsevimab that's nice is that it doesn't interfere with diagnostic assays. So what does that mean? It means if a patient or a child was going to get Beyfortus and then went on to get a lower respiratory tract disease, and then we wanted to do a PCR to see whether or not it was RSV, getting Beyfortus doesn't interfere with the results of that PCR. Now we know there's a lot of vaccinations that are recommended for pregnant individuals during pregnancy, and we have kind of a short time window to see these individuals. So let's discuss co-administration during pregnancy. According to the guidelines, we are able to give Abrysvo concomitantly with other vaccines, including influenza or COVID or Tdap. And at this point in time, there is no available data on simultaneous co-administration of Abrysvo in pregnant people, but there is limited data in non-pregnant people, which is what we use to make the recommendations. They did find that there was decreased immunogenicity of the pertussis component of the Tdap vaccine when it's co-administered with Abrysvo, but it's unclear how clinically significant this is. Still, CDC, ACOG, SOGC permit co-administration. So Abrysvo versus Beyfortus, when to use both? Well, we've heard from NACI that nirsevimab is preferred over Abrysvo. If it's anticipated that the baby is going to get nirsevimab administered at birth, then Abrysvo during pregnancy may not provide added benefit for the healthy infant. So there's no added effect of getting both. All the effect is kind of is given from the administration of nirsevimab. So there are scenarios, though, where we might give both. Let's talk about them. So if Abrysvo was administered to the gestational parent, NACI recommends that they still get nirsevimab in the following two scenarios. The first is infants who continue to meet that medical criteria for high risk for severe disease, which is shown here in really, really small font, but it's cystic fibrosis, chronic lung disease. You've seen these lists everywhere. And then the second scenario is, for example, if an infant was born less than 2 weeks after administration of Abrysvo. So if that infant is born prematurely, it's been less than 2 weeks since the administration, they should still get Beyfortus at birth because it takes at least 2 weeks for the transplacental transfer of antibodies to occur, and we are not sure if the baby got the protection they needed. These are the only scenarios where we would give both. Otherwise, it's an either-or approach. So when we talk about anything for babies, what I've found speaking with families, especially at the hospitals, is what they really want to know is, 1, do I need it? 2, does it work? And 3, is it safe? Hopefully we've covered the first 2. We know we need it because RSV causes severe illness. It does work quite well. We've covered the efficacy data. And let's talk now about the safety profiles of each of the products. Here is Beyfortus' safety profile according to the clinical data. It had a similar safety profile as placebo. So some rash at the site of the injection, some injection site reactions like swelling, and then fever, which actually was slightly less than the placebo group. So really has a similar safety profile to placebo, but also to palivizumab, which has been on the market for 20 years. And as we discussed, has a very safe kind of side effect profile, safe and minimal side effect profile. So that's quite reassuring for patients and parents to hear. So this is clinical trial data, but what I also want to point out is that there have been now over 2 million doses of nirsevimab administered around the world, and no significant safety concerns have been identified. Looking at the safety profile of Abrysvo in clinical trials, when we look at Abrysvo versus placebo, we see a lot more injection site pain versus the placebo group. We see more redness in the vaccine group, swelling in the vaccine group. In terms of systemic reactions, we see a little bit more headache, muscle pain as well. So these are a little bit more of a significant side effect profile here, but again, fairly mild, predictable side effects that happen with most vaccines. So now let's jump in. We know that nirsevimab has been approved in the States and Europe since the last season, and we have some other clinical trial data as well on its efficacy and safety from real-world application. So the first one is a Harmony study. This is real-world data from Europe in 2023. This was published in the New England Journal of Medicine. It took place in France, Germany, and the United States, and it was an open-label trial. So it was a lot more similar to the real world in the sense that it compared nirsevimab with no intervention. So instead of placebo, they just got nothing, which is more close to what would happen in real life. And we saw similar efficacy in terms of RSV associated hospitalization, hovering around the 80% mark, 75% for severe lower respiratory tract disease. But I think what's the most interesting part of this slide is this number over here, which is all-cause lower respiratory tract disease hospitalization, which we still see a 58% efficacy. And that's interesting because it's not to say that Beyfortus works for other viruses, so all cause, meaning not just RSV associated, but it does mean that how much RSV is not coded for or PCR confirmed, even in those hospitalized infants. So that's probably the reason we're seeing a reduction in all cause hospitalizations. This is a map that's been quite widely shared, but I really like this slide. It really shows you how much data we were able to collect last year in the real world. There's different levels of uptake in each jurisdiction, but you can see the efficacy ranges shown in purple range from anywhere from 81% in Spain to up to 91 to 98% in some places in the States, which is a really wonderful number to see. We can see that it works quite well, and this is even better than the clinical trial data. The other numbers that I like to look at here are those shown in green. I find them really interesting because what it's showing us is RSV-related hospitalization reductions compared directly to the previous year. So in Spain, where we saw really good uptake of nirsevimab through their publicly funded program, we saw an 89.8% reduction in RSV-associated hospitalizations in just 1 year. In Luxembourg, in green as well, you see 69%, which is still pretty good, a little bit lower than Spain because their uptake wasn't as great. But really what we're seeing on this map is a complete change in the landscape of RSV and what it looks like around the world in just 1 year of implementation. So sometimes when we talk about vaccines, immunizations, we like to know the number needed to vaccinate or the number needed to immunize. Clinical trials looked at this. On the top half of the slide, see the numbers needed to vaccinate range from 20, 48 to 53 for very severe. But really, when we looked at the real world evidence, this again is from Glacier, Spain, where we had great uptake. We see that RSV-associated hospitalizations were reduced by 90%, and the number needed to immunize to avoid only one RSV-related lower respiratory tract hospitalization was 25. So you can imagine we see 25 babies in just a few days, and meaning that if 25 infants received nirsevimab, they were able to prevent one RSV-associated hospitalization. These are really good numbers needed to immunize. I've seen numbers for other vaccines be as high as 60 to 300. So 25 is quite low, and it shows just how well this immunization works. So what's happening around the country? Let's talk about what's been announced so far to date. To my knowledge, at this point in time, only 3 provinces have confirmed they will be doing a broad infant immunization program. The first is Ontario, Quebec, and then Nunavut. Most of the other provinces are going to be continuing with Synagis this year. And let's talk a little bit about Ontario's program specifically. This year, Ontario has taken a bit of an expanded approach, which is much more broad than the NACI recommendations. Beyfortus is currently funded for RSV prevention in infants who are residents of Ontario and meet any of the following criteria. So they're born in 2024, or they're born during the 2024-2025 RSV season, and then those high-risk children up to 2 years of age with any of the following kind of high-risk criteria written here: Down syndrome, cystic fibrosis, congenital heart disease, etc. What's interesting is that this is a little bit more expanded than NACI, as I said, because it can be any baby up to 12 months old. However, if a baby was born in January 2024, for example, and then they waited until February 2025, they would no longer qualify. They would have aged out of the program. So this is a bit more expanded kind of as like a catch-up. But we do think that next year, Ontario is probably going to tighten this up and go more in line with the NACI recommendations of just under 8 months of age. Let's look at, they also recommend, not recommend, but they will also be covering Abrysvo, which is available to pregnant residents of Ontario, again, between 32 to 36 weeks gestational age, who plan to deliver near the start of or during the 2024-2025 RSV season. It's expected to protect the infant from birth up to 6 months of age. And this is taken directly from the Government of Ontario website. They do still recommend, they remind us that NACI recommended Beyfortus as the preferred product due to efficacy, duration of protection, and safety profile. And only one of these products is recommended to protect infants. Using both is unnecessary, except in certain circumstances. For example, a high-risk infant or less than 2 weeks between administration. Let's look at Quebec's program as well. The Quebec immunization program said that they would cover nirsevimab in hospitals and local service points for the following categories of infants. So all infants going into their first RSV season that were born on or after April 2nd. Again, this is a little bit tighter than Ontario, more in line with the NACI recommendations of 8 months or under. And then if you have no risk factors, you're not going to be eligible in your second season. We know that. If you're an infant with additional risk factors and you're born on or after February 2nd and born between March 2nd to February 1st, if you're still high risk in the second season. So as far as I know, there is only provincial coverage for nirsevimab and not Abrysvo. So let's quickly discuss the timing and appropriate administration setting for nirsevimab. As we know, according to the product monograph and the guidelines, it should be administered as close as possible to when that child is going to be exposed to RSV. So if they're born during the season, this is pretty easy. We're just going to administer it at birth prior to discharge. So before we send them out into the real world and they get exposed to all these germs, we want to give nirsevimab right before they leave the hospital. So it'll be administered ideally, we hope, in the hospital prior to discharge. It'll be 1 dose at birth that will take them throughout the RSV season. Now, if an infant is born outside the RSV season, we would try our best to administer their first dose of nirsevimab as close as possible prior to the start of the RSV season. So that's going to be October onwards. This can be timed with their regularly scheduled 2, 4, 6 month well baby visits. They're already in the office. We can give it to them concomitantly with those vaccines as well. We also will be looking to the government for kind of variability in RSV seasonality. So the regional considerations for nirsevimab administration, depending on what the season looks like in a given jurisdiction. They do measure kind of seasonality with wastewater data, RSV hospitalization data. And so we will look to them for kind of recommendations in each jurisdiction. Again, it's a single dose for the entire season, so it should protect the infant for the entire length of the season. So a quick summary of what we've talked about today. We know that all infants are at risk of severe RSV, and it does lead to primary care visits, ER visits, and hospitalization, even in those infants that don't have any underlying comorbidities. I like to tell my parents about this when I see them at the hospital. And right now I'm recommending that they get their nirsevimab in their primary care offices since we don't have it in the hospital yet. We looked at the NACI recommendations that nirsevimab, which is a long-acting antibody, should be used in a universal program. For the first time, we have a program that protects all infants against RSV instead of just high-risk ones. And nirsevimab is preferred over Abrysvo, given its higher efficacy and possibly longer duration of protection. We know that Abrysvo might be considered at an individual level, especially if we think the baby is not going to get nirsevimab for whatever reason, whether it's supply issues or the parents have a specific preference for the maternal vaccine, but it's not recommended for a universal immunization program at this time. We've seen data from various countries that have already implemented publicly funded RSV prophylaxis programs with nirsevimab, and from the 2023-24 season, we've seen effectiveness in reducing RSV hospitalization between 82 to even 98% in the US. This is consistent, but even better than clinical trials showing that efficacy around 80%. And we know that safety has been studied for these products, both in clinical trials, and it continues to be monitored worldwide. With over 2 million doses given, we have pretty good safety data. So for more information, as I said, communication with our local public health units for ordering and supply will be ongoing, and it depends on every personal local public health unit. The Canadian Immunization Guide and the ministry data is quite helpful, just as a review of some stuff that we discussed today, as well as the tables which show the data that help them make their preferential recommendations. The fact sheets, there are ministry fact sheets available for providers and families. The PCMCH fact sheet is quite neatly done as well. There's one for providers and families. And then there's lots of data on the Ontario Midwives Association website, which I found quite helpful as well. So thank you, everyone. I'm going to stop sharing my slides, and we are open the floor to questions. Thank you.
Great. Thank you so much for that very informative presentation, Dr. Graywall. We do have a question. Somebody's got their hand up. So Emmanuel, either you can put it in the chat or you can unmute yourself as you wish.
Okay, great. So I just wanted to clarify that I understood correctly. Basically, so for healthy infants, they will be offered protection in the first, we could say 12 months of their life, but in the second, so 12 months to 24 months, then they wouldn't be offered a second dose, even though they're no longer covered?
Great question. So it does get a bit confusing. So the easiest way to remember it is that all infants will get a dose of nirsevimab in their first season. We really want to protect every baby, whether they're healthy, preterm, or high risk. And then only the high risk babies get a second dose. And again, you or I, in primary care are probably not going to be seeing those babies, so we don't really have to worry about that. But it's only a bunch of only the pediatricians will decide and determine which of those high risk babies get a second dose. Hopefully that clarifies.
It does clarify. It's just confusing because we are telling parents there's a risk for the first 24 months, but anyway, yeah. Okay.
Yeah, well, the risk is highest certainly in the first year of life, I would say, especially when we look at hospitalization data. And I'm happy to share some graphs after. It's really nicely shown where hospitalizations are highest in the first 12 months, so first year of life. And then they really drop off quite neatly, and only high-risk infants are really hospitalized by the age of 2.
Thank you.
No problem. I'm happy to share the slides, no problem.
Thank you. That's great. That's another comment. Excellent. And in terms of maybe a sub piece in the question that Emmanuel had is also that in terms of the timing of when the infant would receive it will vary according to the jurisdiction. Like you were saying that the recommendations in Ontario are broader in terms of who's eligible to receive the nirsevimab, while in Quebec, and I don't know if you have any details about Nunavut, but maybe they're closer to the NACI recommendations of the infants that are less than 8 months. Is that correct?
Absolutely, Valerie, you've summarized it quite well. So yeah, Ontario's taken a bit of an expanded approach. My understanding is because they kind of want to play catch up for all those babies, born last year or late last year that will still be under 1 year old by the time this RSV season hits. Sorry, not born last year, but born early this year. That will still be less than 1 year old by the time we get RSV season, so November and December. But next year, they're probably going to limit their criteria again to be more similar to Quebec. I don't have details on exactly how Nunavut is planning to roll this out. But we'll keep an eye on what the announcements each province and each jurisdiction makes for sure.
Wonderful. We have another question in the chat from, hope I'm pronouncing it correctly, Jinya Stephen, asking about the Ontario Hospital Implementation Strategy.
Wonderful question. So I also work in an Ontario hospital, and we are still waiting for our hospital to come up with kind of a workflow for our patients. Really, what we're thinking is that it's going to be administered as close as possible to discharge towards the end of the 24-hour period. And the reason for this is we need an opportunity to get to chat with the families, to get consent, to really discuss this new immunization. I think a lot of families will have questions about it. So instead of doing it in labor and delivery, we want to do it. We're thinking to do it on the mother baby unit. We still haven't received supply or much news about that. But I think every hospital is currently working on their own kind of individual policies and implementation strategies. This is certainly a topic of conversation at my hospital and others as well. And I think it's still a work in progress. Is there information about whether the Abrysvo vaccine will be funded for pregnant people like Tdap is? Great question. So in terms of in Ontario, it will be publicly funded if the pregnant individual does not plan to have the child get nursivimab at delivery. So in that case, it will be funded kind of as an either or approach. And then they will likely not be offered nursivimab, or according to the guidelines, should not be offered nursivimab in addition to Abrysvo if they received it during pregnancy. So we're hoping to get, record keeping and have an idea of which individuals received Abrysvo and which ones didn't. The practical implementation of that is a whole nother can of worms of how we're going to keep that records and data. But really, it should be an either or approach. And that's just Ontario. To my knowledge, the other provinces are not publicly funding Abrysvo at this time.
Which would mean, just to clarify that piece, which would mean that people would have to access it privately through pharmacies, for example, right? That would be the other option in terms of receiving RSV Pref.
Right, exactly. So you can still access it, you can still order it, and they would just pay out of pocket for those cases. The other thing, kind of continuing on that, is there is no private market though for nursivimab or Beyfortus this year. All of the supply is going to the publicly funded programs, so there won't be an opportunity to buy nursivimab for the patients that want it. I don't know about BC at this time. I'm sorry, I don't want to speak out of turn. I don't know what the province is planning there.
As far as we understand, I don't believe that it is publicly funded at the moment. There was a webinar recently with the Alberta physicians who were saying that they were also not funding it publicly, that it was palivizumab that was going to be the option offered again for high-risk infants, as far as I understand.
Yes, I agree. That's what I've been hearing as well. I think beyond Ontario, Quebec, and Nunavut, the other provinces are going to continue with Synagis this year.
Okay. And perhaps in terms of like midwifery specific information, in terms of providing the nursivimab, it's not something that is covered in the specific list of products at the moment, but could be available through medical directives, as far as I understand. I don't know if we have any Ontario colleagues that want to add any information about that, if they've heard anything else in terms of that. And in terms of the Quebec context, it will be available in birthing centers. And we have a hand up from Sarah Donnelly Harnham. Did you want to unmute yourself, Sarah?
Yeah, sorry, I got booted out of my computer. So I live and work in Newfoundland and Labrador, and I don't know if you've heard anything about I think we're staying with the synergists. I think that's what's happening right now. But 2022, the Janeway actually, which is our children's hospital, had to cancel surgeries because of the surge in respiratory infections in children. And I'm wondering if there's anybody outside of the province that could help us advocate for changing our strategy with regards to RSV.
Absolutely. I think it's a great question and a great point you bring up. I think all of us are kind of, especially not in the provinces that haven't received it, frustrated because it's been, in the market for 2 years now, and we really want to protect as many children as possible. We know it works well. In terms of people to advocate, I know that, even people that work with Sanofi on the medical side, they've been excellent advocates. They have open lines of communication with the ministry, is my understanding. And that's kind of how they've gotten nursivimab approved in Ontario and Quebec. So I certainly think reaching out to them would be an excellent resource because they already communicate with ministries in other jurisdictions and provinces. I would suggest trying that. And, that would be, my suggestion for advocacy.
Thank you.
No problem.
There was another hand up, I believe. Ilana, did you want to unmute yourself? Or if that's not working, you can put your question on the chat. Oh,
Oh, I
okay.
think she said, yeah, okay, no worries.
Okay, it was just okay, no problem. And we have another comment from Jinya. Local hospital doesn't have this issue on their radar or their research to bring to their attention regarding their implementation obligations.
I would bring, I mean, my local hospital in Ontario, I mean, the ministry has been quite clear on their recommendations. Nurse is coming out. And I think if you're looking to physicians, there was a really good webinar by the OMA that is on the website for physician specific, which is a good resource, I think, to bring to their attention regarding the obligations to implement Nursivimab. Certainly, this is, now the responsibility of the providers, and they've been quite clear that this is something that we need to start doing to keep up to date. So our hospital, for example, has already started, even though we don't have it in stock. When I see newborns at the hospital, I'm counseling them on, checking in with their family care provider in 4 to 6 weeks when we expect to get it. We're looking at what I'm hearing from the from the company and the ministry is, end of October to mid-November is when we should start seeing Nursivimab. And so, yeah, we're already gearing up for that. That's not too far away. So I can share the OMA webinar for Eugenia if you'd like to get access to that and maybe chat with your colleagues about it.
Thank you. So additional resources we'll be able to provide afterwards as well. Excellent.
Absolutely.
Okay, are there any more questions? So it's complex to try to cover all the various jurisdictions. We realize that everybody's in different contexts. So trying to provide the broad strokes for everyone.
That's right.
And links, yeah, for additional information and resources.
Absolutely.
The webinar you were talking about, so you said it's on the OMA, Ontario Medical Association, where they have, I see that they have some information about the RSV program, and then, but I haven't found the webinar itself yet. They're talking about who's eligible, who's covered.
Yes,
So
the webinar, I do believe it's behind like a login. So I think it's only visible to physicians. I'll double check that for you, but I definitely had to log in to view it. So I'll see what I can do in terms of sharing that. I'm happy to send over an email afterwards if you like.
Okay.
I can see.
Here's the general info.
See if I can pull it up, but
perfect.
Immunization.
And if anybody has, even later on some information about your own jurisdiction as you receive updates, if you're wanting to share them, my understanding is that in Quebec, they've set the date for the rollout of the campaign is already started, as far as I understand, because it was October 1st that they had that they established as a start for the campaign. I don't know if you colleagues from Quebec, if you have any information about if you've seen that already taking place. If these are already available. I don't know if we still have some colleagues there from Quebec on the call. If not, you can share that information with us later. Excellent. Well, it looks like we've covered all the questions, I believe. I don't see anybody else with their hands up or no comments in the chat.
Wonderful. And thank you again for having me. I think, it really is an oversight that midwives weren't given, especially in Ontario, the ability to order and administer. And we're advocating, strongly for that, at least on my hospital level. For now, it's a medical directive, unfortunately, that has to be applied. And we're hoping that does the job for the time being. But I do think that it's a barrier to care. And it should be kind of put into within the scope of midwives as are other vaccines. So,
thank you. Wonderful. Well, thank you again for your time, Dr. Graywell, and thanks for everybody for joining this webinar. We hope it's been informative, and all the information will be on the website by the end of the week or early next week. Oh, we have another. Oh no, it's just a a kudos, I think, from Gina. I don't think it's a question there, but thanks for being here, everybody. And we look forward to sharing more information as we receive it as well from other jurisdictions. Thank you very much.